what are the main objectives or aims that we are going to have. That is what is there in this slide. So what are they? We are going to see how a disease transition, or what are the trajectories that a disease or life-limiting illness can take. Primarily to know what is a disease and what is illness. Any disease, diabetes, hypertension, it is the pathological disease, that is disease. Whereas illness looks into something little bit more than that. It looks into the person who has the disease. So that is the main difference. It is a character, or it is the nature of the disease causing changes in the person. So the next thing what we are going to see, we are going to see the principles of biomedical ethics and their application in end-of-life care. That is what I mentioned. Why we will see these important ethics or ethical issues along with the cases. Next, explain the existing legal provisions that are there in India to facilitate end-of-life care provision. And last but not the least, we will touch upon important phrases like what is DNAR, what is withholding, what is withdrawing of treatment, and advanced care planning. Next slide, please. As I mentioned, what are the trajectories or transitions in any type of illness? If you see this picture or if you see this slide, we will go from left to right. Leftmost, what you're seeing is diagnosis. When someone has any form of symptoms, when that starts off, he or she will be having various types of investigations. So based on those investigations, some diagnosis is made. So if you see in that first part of the graph, there is one dip. So basically some form of, they are not normal. There is a difference or decrease in their normal status. And then once the diagnosis is made, you have some form of treatment or corrective management. So that is what is mentioned as disease containment. So all methods are used to contain the disease. And in that stage itself, you may see the function or the normal function, whatever the person was doing for themselves, may or may not be impaired. And then you have a phase where decompensation, where the disease entity increases. So the symptom or difficulty in maintaining their day-to-day living activities may be more impaired. And that is when some amount of dependency develops. So that is where, see, you would have all seen in the first few sessions what is palliative care, when you should start palliative care. It is better if palliative care is started early in the phase. So that is what is mentioned. The palliative care, if it coexists along with curative care, so these specific symptoms can be managed. And then if the treatment is not successful or cure is not possible, then it goes into a phase of decline and terminal stage, where which will be end of life care, and it ends up in death and further bereavement. So this is the full transition or how a disease can progress. Next slide. We will see a little bit more on this topic itself in this slide. Basically, you have got four proposed trajectories of dying. This will give you a little bit more insight on what I have been telling before. So in this, what you have is the whole number of patients or the whole population will fit into one of these four trajectories of dying. So, and we'll see individually about each and the probable percentage also. So the first one is sudden death. What does that mean? So certain number of patients or people can have sudden death. Examples, well-known examples are road traffic accident or cardiovascular collapse. So what happens in that? If you see the first graph, see the function is mentioned on the vertical axis and time is mentioned on the horizontal axis. So in that, if you see the function. So the function of someone who has sudden death he could have been normal, doing everything by themselves. But as I mentioned, due to the event, death happens. Normally, this type of death happens in about 7 to 10% of the population. Coming to the next graph, what is mentioned as terminal illness. Normally, what we say is cancer or oncology fits into this graph. This type of decline or death is said as waterfall effect. They are normal, maintaining their activities. See, again, in this also, the performance is high. So what happens? They are able to do things. But once the disease is diagnosed, the decline is very rapid. So that's what is meant by the term waterfall effect. So if we see, they were doing everything, but once the diagnosis is made, the decline is quite quick and they may end up dying. Nearly 15 to 20% of the population will fit into this category. Coming to the third one. Third one is organ failure. This is one of the large group which all of us will be seeing. All non-communicable diseases, any end organ failure, cardiovascular, respiratory, renal, neurological, everything will fit into this. So it is important that all of you understand this graph very well. See, if you see on this, where you have the performance or function, to start off itself, it is not near the high level which you have seen in the first and second graph. See, that itself is slightly lower. Why? Because these non-communicable diseases do cause some amount of end organ damage as a reason of the disease itself. So their function, see, these things may not be seen very obviously externally, but some form of impairment will be there. So to start off itself, function is slightly lower. Then what happens? Each dip will correspond to each hospital admission or some form of some episodes. Either it could be an infection or some amount of disruption in their normal functioning. So most common thing is pneumonia or urinary tract infection, some form of infection. What happens? Each dip, if you see, they have the episode and they recover. But each time when they recover, they are not back to their normal. See the difference between the first episode and the third episode. If you extrapolate how they have returned back, if you extrapolate that point to the vertical axis, their function would have been reduced at least by 25% of how they started. If these episodes happen in short time intervals, so the decline will be quite rapid and quite significant, which we have to keep in mind. So this type of decline, nearly 50% of the population will fit into this category. So one important thing to understand, for example, they have 3 episodes within 1 year. So their functionality would have been reduced already. To start off itself, it was less. As a result of the 3 episodes, it would have come down to a significant extent. Normally, you will be hearing this term. To start off, they were better. They walked into the hospital or something like that. As the second or third episode, their mobility may be reduced. They may need some extra support for their day-to-day activities, ADLs, what we say, no? So those are things. This will give you an idea why that is happening. So because of their own decline in their health condition, it is revealed as a reduction in their performance status. Okay, and the fourth one is frailty. Normally 80, 90, 100-year-old patient, Oh, if you see those type of patients, they will all come into this category. If you see in this line, see the function. Their function is already on the lower side. It is closer to low when it starts off itself. And it is a very, very slow, gradual decline. So these are the 4 important proposed trajectories, which it is important to understand. If anyone has any queries in this, we can go through this, or I don't mind taking you all through this once again also. Anyone has any queries, please unmute and ask, or type in the chat box. Anyone has any queries? No. Okay then. In that case, we'll go on to the next slide, please. See, next we will come on to, we will see the main important, what are the cardinal principles of medical ethics. It is autonomy, beneficence, non-malfeasance, and justice. And how are we supposed to do or go about with these things? The main things, we have to follow all this with the 3 things mentioned there. You have to always do truth telling, and we have to have due respect for life, and also due respect for the person which I mentioned. And we have to do all these with 3 more factors, which are, click on this slide please, with due dignity for the patient and family, with utmost honesty and clinical integrity from the medical professional side. Next slide. Okay, from now onwards, we are going to see with cases, the principles what we saw, we will see and discuss all of them through these cases. The first one, we have got a 78-year-old woman who has stroke, hypertension, and type 2 diabetes, who is already cachectic. Hope all of you understand cachectic means she's already skin and bone. She's bedbound and she's dependent on all activities of her daily living. That is, she cannot do anything for herself. And she's brought into the hospital with reduced urinary output and reduced oral intake. She's at that time of admission, she's diagnosed with urinary tract infection and end-stage renal disease. She is advised for antibiotics and dialysis, but patient refuses. But her sons say they want her to have the dialysis done. What is your take? How many of you will, like as I mentioned, you can type or unmute up. Who would like to go with the patient's wish of refusing, or who would want to go with the son's wish, and both ways to give reasons?
Dr. Sunitha Rani has said
son's wish. Both of them have said son's wish. Okay. Anybody else? Very good. Sudhir Singh wants to go with the patient's wish. Okay. Now, each one of you, whoever has said whatever response, if you could like unmute and say, why do you want to do that? 2 people have said, okay, equal. 2 have said they want to go with the patient's wish, and 2 wants to go with the son's wish. If you could just unmute and say, why do you want to go with the son's patient's wish, Dr. Sudeep and
Because the patient is already suffering from diseases, hypertension, diabetes, stroke, and is bedbound and getting sick.
Okay.
Better to go with end of life care. It won't improve too much of his future prognosis. I think the dialysis
No, main thing why we are saying is because that is the patient's wish, isn't it? So it is our duty. Okay, we'll hear from the other persons who have said that also, and then we will come to why, what we should do. Yes, that also very good. What needed explanation, Dr. Preeti has also mentioned. No, two people had mentioned, no, they want to go with the son's wish. If they could say why they wanted to do so.
Ma'am, if we don't undergo treatment, then it is like euthanasia.
No. Okay. But the thing is that will you not consider what the patient wants? Okay, in that case, what is the meaning of autonomy? We saw the first one of the four principles is first one is autonomy. Can anyone tell me what is the meaning for autonomy?
So freedom.
Freedom.
Right of
freedom, independence, and right. Okay. Meaning for that word is freedom and independence. See, the patient, every patient has their own wish. They have their own right. They have the right to make an independent decision. Okay. So that is something very important. Like, who was it who mentioned that if you don't give treatment, can you tell Sangeet, who was that word? Because or let me check in the chat box, because they had, was it Dr. Madhu or Dr. Sunita who unmuted and said that they want, if they don't go, it will be euthanasia. Can I know who it was?
Ma'am, because our aim is to help choose the appropriate line of management based on clinical situation.
No. Like, exactly, that is, but someone said that, was it Dr. Madhu who mentioned that if you don't give treatment, then that will not.
Yes, ma'am. Every patient who is in critical situation wants to die.
No. So see, to have those clarity only, you're having this session itself. First point is autonomy, no? The patient has the wish, but we will see there are some more points also into this. Main thing is that patient's wish has to be respected, and patient has freedom to make a decision or choice. Yes, every patient needs to have treatment, but every patient also needs to know that sometimes treatment, as we were telling, you had so many things we have seen, no, that it is end stage renal disease, means even dialysis will not be helpful. So can we treat everyone always, or can we be will we be able to cure everything always? If the end stage renal disease, the kidney is not functioning, the functioning kidney is only, existing functioning kidney is only 10%, even if you do dialysis, will it be successful? So that decision is decided on the patient's disease per se. So here, if you see, already reduced urine output and patient is on end stage renal disease, where the treatment will be futile, as mentioned. So Not that you don't want to give treatment, but you should be able to give treatment in a situation where it will be possible to get a positive outcome. So that is what has to be considered and then made a decision. And as we saw in this condition, because patient is already not able to do anything, she is depending on everyone for every activity. And her medical condition is she's got already diabetes, hypertension, end-stage renal disease, which will not be correctable with dialysis. And she is already having reduced urine output. And this time another episode of urinary tract infection. I said that type 3, how the functionality when it is coming down, the organ function is also coming down. So that is why that graph I mentioned, and that is something to be kept in mind here. The sons want her to have, but sons don't know, may not know what about her current condition, about the renal end-stage renal disease. We don't know how much whether they know. So now it is a responsibility of the medical team to find out how much the patient and the family know about the disease. So here important factors, patient's autonomy. That is, patient has the right to make the decision or call on what the patient wants. So that is what is important here. Some more factors are there. We have to make sure that the patient and family know everything. Next slide. So what will you do? Will you advise the patient? And that is what is the discussion we had so far. Will you advise on dialysis? So someone type that dialysis will not be useful. Okay. And then, so will you not talk to the patient or the relatives? No. You have to talk to both of them separately, make sure that, so that is what you will, all of you would have had in your communication session. It is our duty to explain everything to the patient. Similarly, next thing is we have to respect patient's wishes also. The son wants her to have treatment, but the patient does not want to have treatment. So there, just think of yourself in the patient's position. You know, if it was you in her position, you know that the dialysis will not work, nothing will not work, or will not be positively able to revert the condition. So in those situations, if it was you that you don't want treatment and somebody else says, no, you have to have treatment, how will you feel? So this is what is empathetically making the decision. Okay. And then last one, is it worthwhile referring her to a higher center? No, because already when you have seen that, it will not be beneficial to send. What is the point of sending her to a higher center? So see, these are all medically, in this case, you have seen that everything has been checked and finalized, that her renal function is not very good at all. So that is why this decision is made. Okay, that all these factors have to be kept in mind. Next slide. So in these situations, generally what happens? So autonomy means patient's wish is taken into consideration. The doctor, patient, family, everyone is explained about everything, keeping everything in mind and explaining to them what happens if treatment happens. If treatment does not happen, how will it progress? Every explanation is given, and then finally the patient's decision of will is made effect. Okay. Next, if the patient is awake, alert, can understand, no worries. But if the patient is not able to, for example, dementia, in those situations, what happens? That is what is mentioned in the bottom. We have to find out if the patient has the capacity to make the decision or not. In this one, we saw the patient was awake, alert, and she could say. So always, even if they could say, it is our duty to make sure that the patient is understanding, is fully awake, alert. GCS, what we say, no, she is fully awake, alert, 15/15 GCS, no impairment in her cognition. If everything else is checked, then her decision can be taken. If not, what happens? That is what we will have to. The first thing is we have to make sure whether she can understand ask her to repeat what we say. That will give us an idea whether she has understood everything. Next slide. So this is what you see. Basically, you give all what I mentioned only is coming in this slide. All weather information, where empathetically are you telling the truth? Are you giving respect for all their beliefs? And generally, in our culture here, there is something called as collective autonomy. So that is what, see, the son was telling, but if you explain everything to the son, that dialysis is not going to be helpful. Even if you do dialysis, it will not be beneficial for the mother. Then collectively, they will agree to go with the mother's wish. Okay, that is what is mentioned as collective autonomy. Next slide. On next slide. So these are in all these things, always you have to make sure you have a proper conversation and then make a call. And as I was mentioning, if the patient is not Abe colored, then next of kin or who is able to make a decision, the son, or they might have told someone who will be the responsible person for them to make a decision if their conscious level goes off or something like that. So either they might have made a decision before like that, or as medical professionals, you will talk to the family, explain everything, and then make a call on what type of decision, who will make the decision. One more click. See, patient autonomy is to be upheld at all costs in medical ethics. See, these are the differences or queries everyone asks. See, I was not pinpointing at Dr. Madhu at all. See, better these type of queries have to be clarified here. Many may think, oh, whatever the son says, that only I should follow. No, what is mentioned here? Patient's autonomy is to be upheld at all costs in medical ethics. That is where the duty of the doctor, nurse, and the whole team comes. It is your duty to explain everything. Tell that this is the condition and these are the outcomes. And this is your mother's wish. Your mother's wish should be always upheld. And once you explain everything, then sometimes it may be one conversation. Sometimes it may need 2-3 conversations. Every patient and relative will not be the same. Some might have been with the patient, seen her go through all problems. So then your job may be easy. Some might not have seen the mother at all for 20 years. Suddenly they may come and see. So that stage, they might not even know how their mother was. Okay, so there the responsibility comes on who has to explain. You may take more sessions. Like same day itself, you may have to talk to the family, you may have to talk to the patient, and then explain to them 2-3 times. Sometimes they may not be able to accept and digest everything in one go. So those type of individual cases you have to deal with as and how it goes. Okay, next slide. See, as I said, if the patient has dementia, what happens? Next slide. Okay, then as I said, then we have to decide who will be the surrogate or who will be the next person to make the decision. In that, you've got so many options. It could be next of kin. That means who is the next person. Like if it is parents, it could be son, daughter, something like that, or brother, sister, or husband, wife. It all depends who is the next person, next in relationship to the patient. Or it could be a nominated person. Sometimes they might have already told that somebody else will be the person who will make the decision. Or the next one is they might have written some legal documents and kept. See, sometimes there may be only one person. So they might have done all these and kept all. So last, if nobody is there, then too, it is the responsibility of the medical team to do everything in patient's best interest. I will repeat once again, this is very, very important. Always any decision done should be in patient's best interest. That means what? Whatever is best for the patient only has to be done. That is what you saw in the previous slide also. patient's autonomy has to be upheld at any cost. So, because as professionals, it is our duty to look after our patients. So, that is, even if someone is not there, you should do something what is best for the patient. Next, what is given is advance directive. Nowadays, you have many people do write something called as advance directive or living will, it is called. Both mean the same. Either it could be called as an advance directive or as a living will. And that is a medical power of attorney. So this living will is something which the patient might write and keep. If now I am awake, alert, I can know, I can cognize. But suddenly, if something happens to me where I am not in a stage to make a decision, at that time, these are things to be done for me. These are things not to be done for me. They can write and keep. We will see about it at the end of the session because there are some changes which have happened in India also. So that this has been made easy so that if people want to write advance directives, they can write and keep, and the whole process is made easy, which we will see also. Next slide. So next we will see what happens next. Okay. So any doubts so far? Anybody has any queries? So far, is it clear?
Yes, ma'am.
Okay, thank you. Thank you very much. So next is beneficence, means always trying to do, beneficence is do good. As we saw, not autonomy is freedom or independence. Beneficence is, so thank you. Someone has mentioned it's clear. Okay. Next is beneficence means do good. See, the 4 pillars are equally important. So that's why all the 4 you need to understand. Beneficence means it is our duty to do good. Okay. And always see, first point is our obligation to act in the best interest of the patient. And these are few things what I've mentioned again only is mentioned in this. Whether are you doing something right or wrong? So we'll see the next case and that will give more clarity. Next slide, please. Okay. This is a 20-year-old boy with metastatic osteosarcoma of lower end of femur who has lung metastasis and anemia too. Okay. He has a large tumor on his thigh and he is insisting on getting operated. Both patient and the parents are telling that they want surgery. Okay, I'll repeat once again, 20-year-old boy who has metastatic osteosarcoma of lower end of femur. He has a large tumor in the thigh. He already has lung metastasis and he is severely anemic. Okay. Both the patient and parents are insisting that they want surgery. What should the surgeon do? Now you have to keep in mind what all I've said so far. Okay. Our job is to do good. And next is non-malfeasance means do no harm. Beneficence means do good. Non-malfeasance means do no harm. So we have to do good but not do any harm. And always whatever we do should be in the best interest of patient only. Have all these in mind. Then tell me what should the surgeon do.
Surgeon should explain all the situations and critical, what will be the critical later on, and there will be no use of surgery, and you have to carry like the things like that only because of only symptomatic management should do surgeon according to me, ma'am.
See, whatever you said, little bit more we have to tell. Very good. Exactly. So we have to see if you because the patient and parents are thinking if the tumor is taken off, maybe one large tumor, no. So they may be thinking if that is taken off, some relief they will get. No, that is there. See, always they are looking at their point of view. It is our job, all what Dr. Preeti said, but little more. Yes, we have to tell them you have to see all the what is mentioned in the case. Someone has mentioned attendance should be counseled. Yes, so basically we have to tell already metastatic osteosarcoma. So anesthesia, lung metastasis. So with all this, there may be anesthetic risk. And it is going to be a large tumor. So if you all operate on that, already patient is anemic. So the risk is more than the benefit. Okay, so it is the job or duty of the surgeon to explain everything in detail. Anesthetic risk, surgical risk, outcome, and what are the complications that the patient may face after the procedure also. Okay, so telling all this, and tell the next slide, please. Yes, this is what we have to do. Okay, so harm, what are the harm that can happen if we go ahead and do the surgery? Okay, what are the benefits of not doing the surgery? What are the benefits that the patient is thinking that they will get? So when you do this, if you see this, you see whether the benefit and harm, do they balance? The common word what is used is called as risk-benefit ratio. That means what? Is the risk more or benefit more? So you have to weigh the risk and benefit and do whatever is best. If the risk is more, you will not go ahead. If the benefit is more, you will go ahead. You'll see the harm is more than the benefit. Okay. As I said, the anemia, already anemic. So the surgical blood loss, he might become detrimental. We may even lose the patient on the table. Is that right? So that's what Dr. Preeti was also trying to explain. Many of them have mentioned in the chat box also that see, attendance should be called. Exactly. Everything has to be explained in detail to the patient and family and told what are the risks of having or doing the surgery and what are the benefits, and then accordingly further on see what is best and then move forward. Click again, please. Sangeet, you can click. There'll be few more things coming. So exactly, if you explain everything in detail, so then you will not, because the patient and parents are thinking it's going to give relief. But if you explain, initially there may be conflict or anything because they want surgery and you are telling surgery will not benefit. So here, main point what is brought up here is non-malfeasance. You should not do harm. If you just go with the patient and do the surgery, it may be causing harm to the patient. So as we said, we should aim to do good. We should not aim to do any harm. So that is also our duty. So that is what is being mentioned here. Click once again. Or go to the next slide. So, as I said, first thing is do no harm, respect life, and doing no harm is also right. All what I've mentioned only is given here. Click once more. Okay. In this condition, if someone, like I was telling, always will follow what patient said. That is autonomy, isn't it? But what? Even though the patient wanted surgery, we said we have to do no harm. So non-malfeasance overrides autonomy. Why? Again, in patient's best interest. Again and again, always keep in mind whatever is best for the patient, only we should do. So here, even though the patient said he wants surgery, I said we will explain to the patient and tell them, even though you wish, it will cause more harm for you. So we should not do any harm. So that only in those situations, we explain to the patient, and even though they want it, we say it is not good for you. So that is where we are overriding autonomy. Again, for what? In the best interest of patient. So this is something you have to understand very, very clearly. Is that clear? If anyone has any doubt, please do ask now. I don't mind explaining once again. Is this clear? Clear.
Yes,
Okay.
ma'am, you have explained very nicely.
Okay. No worries. No, thank you very much. Okay, the next slide, please. Okay, next what we're going to see, these medical ethics and these type of queries, no, always will be there. Only the clear analysis is what is very important. So we are going to see something called as doctrine of double effect. Whenever some situations or actions are done, two things happen. One may be good and one may be harmful. But the harmful one is not done intentionally. For that, that is when something like that happens, that is when it is called as double effect. And for that, there is something called as a doctrine of double effect. We will see again that also with an example. Okay. Whenever there is an ectopic pregnancy, salpingectomy is done. Is everyone clear with this condition?
Yes,
What
ma'am.
happens is, yes. So when the fetus is in the fallopian tube, so it is an abnormal site. Instead of being in the uterus, it is in the fallopian tube. So what happens? It ends up in an emergency. So a single act having two possible foreseen effects, one good and one harmful, is not always morally prohibited if the harmful effect is not intended. So this ectopic pregnancy is what we are going to see. So this pregnancy, because it has happened in the fallopian tube, to save the mother, what is done? They do laparotomy, they do salpingectomy. When salpingectomy is done, the tube is also removed to save, along with the abnormal fetus there, the tube is removed to save the mother. Okay. So there it is not intentionally. I'm not doing salpingectomy for my will and wish. To save the mother's life, it is done. Here it is no point thinking that salpingectomy will make her fertility chances less. Yes, we know that. But if the salpingectomy is not done, she will not even be alive to have another child. She has another tube with which she can have another child. Okay. So this is an example, because this is a very clear, obvious example. Similarly, like that, you may see when in some situations, when you give a drug, it may have two effects, but you don't do anything like that with a harmful intent. Okay. So the action must be morally good. You must not desire intentionally. For a normal person, you don't go and do salpingectomy. No. Here it is done because the ectopic pregnancy is there. So you should not desire the negative effect and do that alone. The good effect must be as immediate as the negative effect. So the good effect only is important there. And the negative effect happens as along with it. But that was not the intention. Okay. Is that clear?
Yes, ma'am.
Okay. Next slide, please. Next one. This is no. Oh, the previous slide. And this is another case in which we will see the fourth point of the cardinal point of medical ethics. So here we have a 57-year-old male with advanced metastatic cancer of the lung. who is severely breathless due to progressive disease. See, I stress on some points because they are important. And all reversible causes of dyspnea have been ruled out. Okay, so this person has been admitted to ICU he is brought into ICU for artificial ventilation. Okay, to make things clearer, I will give another example also so that you will be able to make a clear decision. You are getting another 27-year-old male with pneumonia, no other medical issues at all, who was fully fit and well working. Suddenly at work, he became breathless, and he doesn't have any other medical issues at all. He is also brought into the ICU. Okay, there is only one bed. You have got this patient and that patient. Which patient should get, from your view, which patient is the ideal patient to be ventilated?
Second one, ma'am.
Okay, okay. Anybody else? Any patient with pneumonia is what is coming up? Is anyone mentioning anything different? Okay. Okay. See, that's why I mentioned this, the second case also, to make. Now let me hear from all of you. Why the second patient? Why not the first patient? Give few salient points for both.
मैम फर्स्ट पेशेंट में जो कंडीशन है रिवर्सिबल है मैम, और सेकंड में रिवर्सिबल हो जाएगी, मतलब चेंज हो जाएगी.
Reversible possibilities are there in the second
और
one.
प्रोग्नोसिस अच्छी.
प्रोग्नोसिस अच्छा है. In the पहला one, metastatic CA, progressive disease, and all reversible cause of dyspnea has been ruled out. So positive outcome possibility is nearly not possible there with the first case because of the advanced nature of the disease. Second, C, severe breathlessness. The breathlessness is not only due to the cancer alone, due to progressive disease. So the disease is still very active and advancing. And they've already tried and made sure that all causes of dyspnea have been ruled out. This is what I've been telling from the beginning. Don't think we are taking blindly one decision. I have been an intensivist, so always I will try level best to save a patient. Okay, that not only me, all of us in the profession, our duty and job is to save. I'm screaming best interest, best interest. So will I not want to save anyone? Yes, I generally say, if we can save someone, we'll put 200% to save someone. But at the same time, if nothing can be done, as I say, no, there is in this scene, all reversible cause of dyspnea has been ruled out. That means what? They have not left. They've tried. They've tried inhalers. They've tried nebulization. They've tried antibiotic. They've tried everything. When all that are not showing, when the patient is not showing any response to any form of treatment, that is what is all reversible causes have been ruled out. Okay. In those situations, no point going ahead and doing something because the outcome will not be positive. Okay. That is what is the important critical decision making situation. Okay. Go on to the next slide. Next slide, please. So should we have already seen this. If next thing, should we resuscitate if we arrest? So because it is not going to be fruitful. So that is when we do not. So that is what is do not attempt resuscitation. If again that one no can be made, some people they might have expressed their wish, it can be done. Or it is a medical decision taken when every reversible cause is ruled out, it may not be worthwhile resuscitating. So that is what is mentioned here. Next slide. So why, between these two cases, why did I ask and why on earth we are talking about this? Because healthcare is a scarce resource. It has to be used wisely and appropriately. Because that not that I am having any age discrimination, no discrimination I have. If that 20 plus patient is ventilated and he survives, he will have a better outcome in his life. And the ICU resource also will be used properly and positively. Okay, everything you have to keep in mind. This healthcare resource has to be used wisely, and everyone has the right to have access. Okay, the 27-year-old who will have a better outcome is definitely bound to have the ICU bed to have a better outcome. Next, it is our response. Third point, are we allocating that precious resource of ICU justly? See, if I am not using it properly, it is my lack of my job, or I am not doing my job properly. So means it holds good to all of us. So all of us have a responsibility to use the resources properly. And last one, are we considering the family resources? See, already if no outcome, if the outcome is not going to be positive, in that case, if you make the patient, if you put the patient on ventilator and make the family spend more money on a not positive outcome, or a non-fruitful outcome, or where the outcome will not be positive or not beneficial, is it right to reduce the family resources? That also has to be considered and taken into consideration whenever you think of putting someone who will not be getting any positive benefit. So that also, looking after the family. See, from the beginning you would have seen, whenever we say palliative care is to look after patient and family, patient and carer, patient relative. So it is our responsibility to look after the remaining family also and their resources. So that is what is mentioned here. So what is mentioned in the boxes? Ethics is knowing the difference between what you have a right to do and what is right to do. So that is why, once again, I will say the 4 points: autonomy or freedom, beneficence or doing good, non-malfeasance or doing no harm, justice or wise utilization of medical resources or healthcare resources. All 4 points. See, all 4 points we have seen with end-of-life care. So that is how I have incorporated both. We have got this whole session mainly considering both, and also with cases, so will give you more clarity. Next slide. So why? Generally, why are we talking about all this? Because end-of-life care consumes 10 to 12% of all healthcare expenditures. And the other 2 points is, main thing is that we have to do all this wisely. It is our duty. So each patient, everyone, we have to explain and use it correctly. Nowhere it should be used inappropriately or disproportionately. Okay. So, and the assessing futility becomes very important. That is what, if some action will not give any benefit, or it is waste, in vain, in those situations, it is not wise or worthwhile to do. So it is our duty to find out that also. It is our duty to find out if some outcome will be positive or not. So if it is not going to be positive, then it is no point, or it is not a right act to do that also. Next slide. So same thing, if it is not going to be useful, it is medical interventions and all should not be just done if it is not going to be. Same what I've said only is there in this slide also. So futility means when it is not useful, it should not be done. So that's why what they've said is, when this dying prohibited, so that's how it is happening nowadays, no? So that is what they are trying to say, because we said dying is inevitable. Can anyone stop Like someone keep on living endlessly? When that is not possible, it has to be accepted and done appropriately. Okay, next slide. Generally, this term withholding and withdrawing both mean the same. What they are is as we saw, for example, the last patient, the 57-year-old who is not having, who is having metastatic disease, no reversible cause of his breathlessness. In those situations, we saw that he is not ideal for ventilation. So what we will continue to keep him comfortable, supportive, symptomatic care. That alone is given. So those stage, that will be end of life. And even in end of life, sometimes they may stop eating, stop drinking. At that stage, when you stop treatment, that is, you're not giving all intervention, antibiotic, those type of things are called as withholding or withdrawing. Both the words mean the same. Okay, and so there's no difference between withholding and withdrawing treatment. That is because some stages of the treatment, there may be when no positive outcome is possible at all. Just your continuing supportive care. Again and again, I'm telling, supportive care will be given, but you will not give additional treatment. So that is withholding or withdrawing. They both mean the same. Next slide, we will see about what is euthanasia. Okay, euthanasia refers to intentional act of ending a patient's life. Okay, which could be at the request of patient, family, or anything like that. But euthanasia is an active or deliberate act, and it is illegal in India. Okay, so euthanasia is a, as I said, it is a deliberate act or intentional act of ending life. That is never legal and should never be practiced. Withholding or withdrawing life support is not euthanasia. See, there we will give supportive care. We are not doing anything intentionally to end someone's life, because someone had this query in the beginning. That is why I am explaining again and again about this. Okay, euthanasia is an intentional or active way of ending someone's life, which is illegal and which is deliberate, should not be done. Whereas withholding or withdrawing life support is, you don't do anything harmful. Okay, you just, nature or time will take its time. Supportive care, all those type of things alone, skin care, oral care, all those type of things will be done. But you may not be giving antibiotics, IV fluids, those type of things are not given. So that is what is the difference between these two things. Is that clear now? Because whoever had the doubt in the beginning, hope I've clarified their query. Okay. 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 Then next slide. So I was mentioning about a few legal things which I said that I would convey at the end. That is about the recent, in India in January of 2023, they have brought in an easy way of doing an advance directive or living will in India, which has been done by the Supreme Court judgment, which says that anyone who has full mental capacity can write an advance directive and keep, and say in which they can very clearly mention what are the treatment they want to have, what is that they don't want to have. For example, they may say, I will like to have a treatment like chemotherapy or radiotherapy, something like that. But if I get to a stage where I'm not having any response, I don't want NG tube. I don't want resuscitation. So those type of clear-cut information they can write and keep. See, that's what they can. An adult having mental capacity to take an informed decision has right to refuse medical treatment, including withdrawal from life-saving devices. So they can say, I don't want to be put on a ventilator. Those type of things people can write and keep. So what they want, what they don't want. So those can be written and kept. And before it needed to be a legal document signed by magistrate and all. Next slide. But recently what has happened is, whoever wants to write, next slide, leave it there. So what they can write and keep, and it has to be just signed by a notary. So that is the recent advancement which has been done by the court, so that they made this as a easy process. Why this is useful? See, because if they write something and keep, even if they lose their decision-making power, this document will be effective, and they, both the family and the medical professionals can use it. And one more important thing in this perspective is that when someone writes a advance directive or living will, it is their responsibility to tell it to their family also. See, as we saw in the first case, okay, mother does not want, but the son is telling that he wants. Similarly, if some mother X writes an advance directive, but the son or daughter does not agree, so it is the responsibility of the person who writes the medical directive or living will to explain to the family, this is what is my wish. Even though all of you may have other wishes, I would like to follow my wish. So it is their responsibility to make the document and also convey to the family what is their wish, and then move forward in that direction. Okay, next slide. It is a legal document created by the patient, and it helps, as I said, it helps the medical team, family, everyone. And all these information, whoever wants more, is available in Pallium website. And if anybody needs or wants more information, Pallium will be able to help them on that front also. Next slide. And in India, you have plenty of well set organizing professional bodies who bring forth these guidelines and directives. In the group, you have doctors, intensivists, anesthetists, legal advisors, nurses. Everyone is there from different walks of life. They're all there. There are lawyers also in it. So it is a collective group which makes the guidelines, so that it is easy for everyone. And all these documents are there, and you will get these PPTs so that you will know what is needed. I think that's it. And one more point I would, we can come out of this presentation, Sangeet. I will add one more point and then we will finish. We can go on. Does anyone have any query before I go ahead? Okay, in that case, what I just wanted to add on was, see, normally one of the important queries is when someone is in nearly end of life stage or something like that. As we saw the first patient, no, who is nearly hypertensive, stroke, diabetes, not at all, she might have been deteriorating for a long period of time, but unable to do anything for herself. Not, maybe I'm going to add on, not eating, drinking for 1 week, 10 days, something in that stage of their disease. We've seen that dialysis, nothing. So if they ask, no, at that point already, so that first case, you add on little more points like patient has not been eating, drinking for 1 week, no urine output. In that stage, what would be your choice for feeding? Does anyone want to If the patient doesn't want, even in that case, what I'm going to say is patient doesn't want feeding. Patient says, I don't want anything, but the family says that they want the patient to be fed. What will
IV
be your
line, we can start, ma'am.
take? Pros and cons again. Already no output. You have that in mind. Already nearly no or reduced output. So what are the pros and cons? Just tell me, and then no, because that is something you may all have a doubt. I don't want you to miss that also. So anybody else wants to say anything else?
No, ma'am, you please clear.
Okay. Well, see, patients wish should be prior. Yes, very good. Thank you. See, a few things what to be kept in mind is what are the ways you can give IV, subcutaneous, NG tube. Okay. So at this stage, will someone go for an NG tube? Okay. So we will not go because it is not going to be useful or beneficial for the patient. In the reverse, if it was early diagnosis, in that case, maybe I may put an NG tube and feed to improve the general condition of the patient, but not at this stage when feeding is going to be of any use or if it is going to be beneficial for the patient. In fact, it may do more harm, fluid overload, and already patient is not eating, drinking. So you have to see the feeding, is it going to benefit or correct any possible correctable causes? So that is how you have to see. And intravenous at end of life stage and all, intravenous fluid also again may not cause benefit. That is why we may not. Subcutaneous also, you have to see the pros and cons, explain to the family, and then see if they are insisting subcutaneous may be the last choice, which may be adopted. And again, subcutaneous can be used. You would have had a session on subcutaneous. You would have known the what drugs can be given, how, when, where, what, all you would have had in detail. So this is something I just wanted to add on, because the harm, always keep in mind the benefit and harm. You have to weigh the risk and benefit, or weigh the benefit and harm, and then make a decision finally. Okay, that's what I wanted to add on. So is there a case presentation or how are we?
No, ma'am, we here don't have case presentation for this batch.
Okay, in that case, I will hand over to the facilitator, and anything else to be added on.
Sita ma'am already told that she is suffocating from disease, so that she is not able to speak.
Yes, she was not well. Even yesterday, I was thinking. Okay, in that case, no worries. Okay, we will ourselves because she's not been well, isn't it? She's
Yes,
not
ma'am.
been back. No worries. Yeah, okay, this being the last session, no. First, in today's session, is there any doubt? Have all your queries been clarified? Because both medical ethics and end of life care, no, you have to make sure that you follow all these ethics all the time. Not that only in end of life care, all the time, but more so, very importantly, at end of life care. So is everything clear, or does anyone want to ask or have any wants to have any clarification? Before also I was, none of you are working in palliative care, if I'm not wrong, because I think I've done one session for this batch in the early phase.
Yes, ma'am.
So anyone has any clarity, any clarification in today's topic?
There is a slight mistake from my end. Usually, these end of life care is the last sessions of many of the batches, so I am got confused. This is the second last session of this batch. Actually, it ends with an SD framework and the role of CHOs in palliative care. It actually ends.
Okay, okay. They have one more session.
Yes, ma'am. Sorry, ma'am.
No worries, no worries. Okay, is there anybody has any queries or anything?
No, ma'am.
So is that all clear, or whatever we have covered today? So the main thing is that to keep in mind that these 4 cardinal principles, and then as we saw in the beginning, you have to maintain these principles with all the other factors. As I said, there should be truth telling, there should be dignity, there should be respect, and you should always see the futility also, and keep patient as your focus or best interest. So everything patient centered, we say. You keep the patient in the middle and then do everything. And at every stage, you have to make sure that it is done in putting everything, all 4 aspects have to be. And normally, like that is why we had cases where one overlaps the other. Okay. So that is why we take it through like this, so that you have clarity with the cases itself, because that is what you will be seeing, no? Rather than me telling what is autonomy, that may not make much sense. When it goes with the case, it will be more beneficial. Was anything else in the chat box?
No, ma'am.
Okay.
Thank you, ma'am, for it. It was very nice session, ma'am. Very knowledgeable.
Exactly. See, the main thing, because this topic as such, no, little bit, everyone has, like we all can have different opinions. But opinion may be there, but the knowledge should overrule. That is what. So clear knowledge and clear understanding is there. Your opinions will transform, and you will be able to make a clear-cut, wise, correct decision.
Ma'am.
That is where it comes help.
Yes, ma'am.
Okay.
Thanks again, ma'am.
Welcome. Then in that case, I will hand it over to you, Sangeet.
Thank you, ma'am. Thank you so much for the wonderful session. Thank you everyone for participating actively and making this session. Thank you.
सर एक क्वेरी है मेरी आपसे. सर इको फ्लैट.
Okay, ma'am. Thank you, ma'am. Thank you for the session. Thank you everyone for the.
Thank you everyone. Good luck to each one. Thank you.